Thank you. So, we'll see some of the very commonly represented ophthalmic conditions, how they can be differentiated or diagnosed, and how to manage, or some of them, how to treat them, and some special techniques like ocular ultrasonography. So, when a patient come with a complaint in the eye, what we have to see first? Where is the lesion, and what is the likely disease? So first we identify where the lesion is, then we have to find out what it could be and what are all the differential diagnosis. Then how to differentiate it from one to the other, and how to treat or manage them. So, to make it little simpler, I would like to classify all that ophthalmic conditions come to us as red eye, blue eye, and the blind eye. So, before coming to the actual topic, I'll just share the anatomy of eye. Everyone knows, just to refresh it. So we have this upper and lower eyelids, sclera, which is the white part, then the cornea, which is the transparent, avascular, non-pigmented part of the eye. Then comes the iris, which will be in different colors, like shades of brown or black, and then the pupil, which is similar to the aperture of a camera, and behind that is the lens, then the vitreous chamber filled with vitreous humor, which is a jelly kind of fluid, then the retina, optic nerve, and the optic disc. So this is basic anatomy of the eye. Then comes the red eye. Most of us have faced this condition, like redness in the eye. It can be in the conjunctiva, it can be in the cornea, or in the uh, other structures like anterior chamber or retina. So, how to approach a red eye? So, first we have to localize where is the lesion. So, conjunctival redness, which is very common, and I think in summer we get a lot of cases of conjunctivitis. So conjunctivitis is the most common cause for redness in conjunctiva. Then other than that, subconjunctival hemorrhage can happen. Then keratoconjunctivitis sicca or dry eye. Secondary to dry eye, we get redness of conjunctiva. Then obviously cherry eye and scrolled cartilage. More than conjunctiva, it is redness of the third eyelid or the nictitans membrane. And simply because of excitement, they can get conjunctival hyperemia. So, first and most common one is conjunctivitis. It can be a primary conjunctivitis due to allergen or immune mediated or infectious, or it can be secondary conjunctival hyperemia due to some adnexal diseases like any ingrown eyelashes or eyelid abnormalities causing constant irritation and causing redness, or tear film disorders, as I said before, KCS. Then intraocular diseases like glaucoma can also cause conjunctival hyperemia, and systemic disease processes. Then, when compared to dogs and cats, comparing dogs and cats, in dogs, most common causes of conjunctivitis are allergy, immune mediated, then mechanical irritation due to abnormal eyelashes, or foreign bodies, then eyelid neoplasms, like eyelid margin papillomas, constantly causing irritation and redness, then KCS, and other than that, infectious, which is very less likely. But in cats, it's mostly infectious, especially feline herpes virus, chlamydia, and mycoplasma infections. Severe redness can be expected. And second one is allergic. So it can be unilateral or bilateral. There will be severe hyperemia or increased vascular supply in the conjunctival blood vessels. Then chemosis or swelling of the bulbar or palpebral conjunctiva. Engorged lymphoid follicles. You can see in this picture small follicles. These are engorged lymphoid follicles. Ocular discharge. It can be serous or watery discharge, especially in acute infections. Then mucoid discharge or thick sticky discharge in chronic diseases like dry eye. or KCS, and purulent pus discharge in bacterial infections. And whatever be the reason, there will be severe discomfort due to this inflammation. So, allergic conjunctivitis is the most common cause of bilateral conjunctivitis in both dogs and cats. There can be periocular redness and alopecia in cases of type 1 hypersensitivity. Most common one is atopic dermatitis. It's very common in beagles and Shih Tzu breeds nowadays. We can see periocular redness, alopecia, and severe red eye. Then conjunctival cytology reveals lymphocytic and plasma cell presence of lymphocytes and plasma cells in these kind of follicular conjunctivitis. You can see multiple follicles in this picture. So this one is a feline herpes virus infection. There is conjunctivitis and chemosis with purulent ocular discharge. Then another one is histamine and immunoglobulin mediated, IgE mediated conjunctivitis. It can be acute bilateral chemosis and blepharodema. So histamine mediated conjunctivitis will typically have this chemosis, swelling of the conjunctiva, like a puffed up appearance will be there. It can be because of any contact allergens, vaccine reactions, especially injectable form of kennel cough vaccines can cause this one, or insect envenomation. Then chemical exposure like irritants can cause this. So in such a case, immediate irrigation with a lot of saline, then fluorescein test to verify whether there is any ulceration or corneal erosion has happened. And please check the surface pH because chemicals can change the pH of the ocular surface. So that has to be addressed with a copious amount of saline wash. And for the management of these kind of histamine mediated conjunctivitis, we can give IM or IV short acting steroids and antihistamines, topical corticosteroids. So this one is a histamine induced conjunctivitis and chemosis in different forms. You can see different forms of that. And invariably all of them have this chemosis, swelling. Then another type is eosinophilic conjunctivitis. It's most common in cats and it can be associated with or without corneal involvement in cats. And on cytology, we'll get numerous eosinophils and mast cells. Then another condition is nodular granulomatous episcleritis, where nodular structure will be present on the conjunctiva with multiple freshly pink to tan colored nodules over that. This is one type of nodular granulomatous episcleritis. This is another type. Here you can see a swelling on the conjunctiva, nodular granulomatous growth, and it is extending into the cornea. So this responds very well with steroids. General treatment considerations. We have to treat the underlying cause. If it is a viral infection, treat for the viral infection. Or if it is atopic dermatitis, we have to initiate treatment for that. So antibiotics are not necessary for these conditions because it is primarily an inflammatory or allergic reaction. Corticosteroids can be used in non-infectious conjunctivitis, but it is contraindicated in most of the feline conjunctivitis cases because it is infectious. Then remove the accumulated ocular discharge because that will reduce the antigens within conjunctival sac and will improve ocular penetration of the medicines which we apply. And obviously, it will improve the patient's comfort. And corticosteroids like hydrocortisone, dexamethasone, and prednisolone, either in ointment form or drops form, are available. Their long-term use can cause crystalline lipid deposition in the cornea. We will see that also later, what it is. Then eosinophilic conjunctivitis cases, long-term therapy tapered to the lowest dose, which controls the clinical signs, is indicated. Then along with that, we can start topical or systemic antiviral therapy, monitor for corneal ulceration, especially when we use long-term corticosteroids, chances of corneal ulcerations are there. So frequently monitor for ulcerations. And topical cyclosporins or topical magistrol acetate preparations, compounded preparations can be used in refractory cases of eosinophilic conjunctivitis. But usually they respond very well with the steroid therapy. Then NSAIDs used in eye are very common ones are flurbiprofen and ketorolac. Both of them are available as such or in combination with antibiotic. We can get moxifloxacin ketorolac combinations. Then gatifloxacin combinations. Then bromfenac is there, and recently nepafenac is available, 0.1 to 0.3 percentage suspensions. So these can be used in infectious conjunctivitis where steroids are not indicated. That is one advantage of NSAID drops. Then other than that, vasoconstrictors, antihistamines and mast cell stabilizers can be used for mast cell mediated antihistamine mediated conjunctivitis. So their chronic administration can cause reduced blood supply to the ocular surface and resultant hypoxia. So it should be for a short-term relief. Nepazoline will reduce the hyperemia or vascularity to the conjunctiva. So it is just for immediate relief. Chronic use is not indicated. Then ketotifen is there. Olopatadine is an antihistamine, which is very commonly used for allergic or mast cell mediated conjunctivitis, and lodosamide. So in cats, Chlamydia felis, Mycoplasma species, and Bordetella bronchoseptica can cause bacterial conjunctivitis. In these cases, we have to add oral antibiotics also. Choice of antibiotics are doxycycline, marbofloxacin, and amoxicillin clavulanate. Doxy and marbofloxacin can be used for Mycoplasma, and amoxicillin clavulanate can be used in young ones, very young ones, where doxycycline is not tolerated, or we cannot prescribe doxycycline in such cases. 0.3 percentage ciprofloxacin or 0.5 percentage moxifloxacin eye drops can be used in conjunction for bacterial infection. Then viral conjunctivitis, especially herpetic viral infections, are very common, and often they are associated with keratitis, corneal ulcerations also. So the use of antiviral drugs, they all are virostatic. They will just arrest that phase, but it will not eliminate or cure the viral infection. So it is not indicated in patients with mild diseases or when there is no corneal ulceration. So the commonly used antiviral drugs are edoxuridine and ganciclovir. Twice a day to thrice a day application is required. They can cause severe corneal irritation, ocular irritation. So that is one limitation for this medication, both of them. And orally, we can try famciclovir tablets, 90 mg per kg, BID. Antiviral therapy is generally reserved for patients with a significant clinical signs and corneal ulceration again. And this famciclovir will be metabolized to penciclovir, which is an antiviral agent. Then next one is subconjunctival hemorrhage. So it is like an amorphous area of deep red below the conjunctiva, obscuring the view of individual vessels. We won't be able to see any vessels, it will be fully red. This is a typical red eye. And it occurs in over-restrained or traumatic injury, clotting disorders, and strangulation. Most commonly, they are traumatic only. Especially, we get these kind of pets or presentation after a spa session, or due to strangulation or over restrained during a spa session. Pets come back to us saying that after giving a bath, my pet's eyes become red. So they will have a dramatic onset, but most of the time they are self reabsorbing, and conjunctiva being the most forgiving part of the eye, it will resolve by itself even without any medication, but we can give topical steroids to make it faster, make the recovery faster. It won't be even painful too. Then Compared to the previous image, we can see that these lesions are little raised over the conjunctiva. It's very evident that it is little raised. These are hemangioma, which is a benign tumor of the vascular tissue. Then coming to the nictitans membrane, evident redness of nictitans membrane can be because of a prolapsed nictitans membrane, which is usually seen in case of exophthalmos or anophthalmos, and cherry eye or nictitans membrane gland prolapse, and scrolled T cartilage. Both of them look somewhat similar. That's why I put both the pictures together. This one is a cherry eye. We can see that gland prolapsed popped out of the third eyelid, and here there is a scrolling of the cartilage which gives support to the third eyelid. T cartilage scrolling we can appreciate. So a hard structure which is scrolled can be appreciated in this condition. Both of them need surgical correction. Then coming to redness of sclera. Most of the time, redness of sclera is not a primary disease. It is a symptom of something else happening inside the eye. Most common reason is glaucoma and anterior uveitis. We will see them later. Then lens luxation that can eventually cause glaucoma. Corneal ulcers that can eventually cause anterior uveitis. Episcleritis, excitement again, scleral injection or increased vascular supply to the sclera due to excitement can cause redness of sclera. Then scleral hemorrhage due to any kind of trauma. We can see such scleral hemorrhage in proptosis cases. Traumatic proptosis, eyeball will be outside and the entire sclera will be red. Episcleral ingestion is the congestion of deep episcleral vessels. Episcleral vessels will be straight and immobile, which runs 90 degree to the limbus. So if you see these ones, these straight ones are the episcleral vessels and the branched ones are the conjunctival blood vessels. Branched ones will be mobile also. If you move the eyelid over the eyeball, these conjunctival vessels will move, but episcleral vessels will not move. That's how we differentiate scleral congestion and conjunctival congestion. So, these episcleral injection is an external sign of an intraocular disease such as anterior uveitis or glaucoma. So, how to differentiate? Already I said movable over the sclera means it is a conjunctival vessel, and pattern it will be more of branched in case of conjunctival vessels, and they will blanch on application of any vasoconstricting agents like epinephrine. Then coming to the redness in cornea. So very common one is corneal ulcer. Other than that, caries or dry eye, which is quantitative or qualitative, can cause redness of cornea. Then glaucoma and uveitis. Corneal redness is basically because of vascularization of the cornea. So corneal neovascularization is a non-specific indicator of a chronic inflammation. So seeing the distribution of blood vessels, we can assess where the location and depth of the inciting cause is. So the blood vessels reveal where the lesion is, not what the lesion is. So there can be three types of vascularization on cornea. First one is superficial vascularization. They are again same like conjunctival vessel. They are branching and long vessels. Because of the tree-like appearance, we say arboreal pattern. They are seen in superficial ulcerative or non-ulcerative keratitis. Whenever there is a superficial lesion, we can see from the limbus branching tree-like blood vessels. Then they will be directed towards the ulceration or injury also as a response to healing, response to injury. Then focal deep vascularization. Deep vessels will be more straight and non-branching. It will give a paintbrush pattern appearance. They indicate a deeper corneal keratitis if it is focal. At one point alone, like for example, if it is at 2 o'clock angle, From the limbus, paintbrush pattern of blood vessels are there means there is an injury or corneal ulceration which is deep near that 2 o'clock angle. If it is 360-degree around the cornea from the limbus, there is deep vascularization means it is an indicative of something inside like glaucoma or uveitis. So you can see all the three patterns here. So in the first image, we can see branching pattern of blood vessels here. So, and there is severe mucoid discharge and pigmentation of the cornea, everything suggestive of keratoconjunctivitis sicca, which is a superficial layer problem. Then this one, we can see 360-degree superficial vascularization in response to this corneal ulceration. Here, there are small paintbrush pattern of vascularization on the margin of the cornea. These ones, it is all around, which indicates there is uveitis inside. Again, superficial corneal vascularization. This picture is very clear. We can see typical tree-like pattern of vascularization. Since the ulceration is in the center, from all around there is vascularization coming towards the ulcer site. The next condition is keratoconjunctivitis sicca or KCS. It is inadequate quantity or quality of the tear film. So basically, tear film is the physiological layer of cornea which protects the cornea and helps in waste like metabolites, removing the metabolites from the eye and to provide nutrition to the cornea and eye. So there are lacrimal glands, conjunctival goblet cells, meibomian glands, and the third eyelid gland in dogs. So three layers are there for the tear film. The inner one is the mucin layer, which is produced by the conjunctival goblet cells. These helps in adhesion of the tear film to the cornea. So major part is the middle aqueous layer, which is produced by the lacrimal glands and the third eyelid gland. So they provide corneal nutrition and waste removal. It is adhered to the corneal surface by the inner mucin layer. And there is an outer lipid layer which prevents evaporation of the tear film. So mucin layer is produced by the meibomian glands. When it comes to qualitative tear film deficiency, there will be a problem with either mucin layer or the lipid layer. Mucin layer produced by the goblet cells, if they get deficient, tear evaporation happens and there will be qualitative dry eye. And if the lipid layer, which helps in adhering the tear film to the cornea, is deficient, that can cause breakage on the tear film or stability of the tear film gets affected. And coming to quantitative tear film deficiency, the aqueous layer, the major part of the tear film, will be deficient. Quantity of the tear produced is deficient. So most common cause for quantitative tear film deficiency is immune mediated. Specifically in beagle breeds we can see. Then other than that, excision of the nictitans membrane gland for cherry eye. So ideally we should not remove the gland. Pocketing technique should be followed because third eyelid gland contributes to almost 30% of the tear production. So when we remove the prolapsed gland, 30% reduction in aqueous part of tear film will be there, and in future that can develop into dry eye. So etiology of case dry eye, immune mediated or T cell mediated inflammation of the orbital and nictitans membrane glands. Then eye or orbital trauma can cause lack of stability of the tear film, congenital lacrimal gland hypoplasia or aplasia. The neurogenic deficiency means sensory innervation from the cranial nerve 5 or parasympathetic innervation via the cranial nerve 7 can cause neurogenic deficiency. If it is a neurogenic KCS, you can see dryness of the nostrils also. Then there can be drug induced due to atropine, sedation, sometimes local anesthetics or general anesthesia can cause dry eye. Sulfonamide use can cause dry eye. Then lack of correction or surgical removal of a prolapsed nictitans membrane gland, as I said earlier. Then local irradiation. Some radiation can cause this one. It's very rare, but can. Then endocrine diseases like very common diabetes mellitus, hypothyroidism, and hyperadrenocorticism also can cause dry eye. Canine distemper virus infection, chronic blepharoconjunctivitis, especially we can see that in atopic dogs. Then chronic blepharitis, blepharoconjunctivitis, or meibomianitis. Meibomian gland inflammation can also result in qualitative tear film defect. The immune-mediated diseases targeting the mucocutaneous junction like bullous pemphigoid, SLE, and all also can cause secondary dry eye. So, clinical signs of dry eye. Most evident sign is the mucoid discharge. There will be thick, sticky discharge. Most of the time, pet parents complain early morning, the eyes will be stick together, eyelids. Pet won't be able to open the eye, or they have to clean it, then only pet will be able to open. So that is like something advanced or later stage of KCS. Then vascularization, ulceration, fibrosis, and pigmentation all are indicative of a chronic inflammation over the ocular surface. Then lackluster cornea means that shiny appearance of cornea will be lost. That is something little earlier. So in this picture also we can see it's somewhat rough. Here you can see a rough surface with the dye uptake. These are the mucin discharge which got dye uptake. And here there is a superficial erosion also, corneal erosion due to the dryness. So altogether it has a rough appearance of the corneal surface. Then conjunctival hyperemia and red eye can be there because of KCS. So most common signs are irritation and subsequent conjunctival hyperemia, lackluster cornea, mucoid discharge, and later on pigmentation, fibrosis, ulceration, vascularization and all happens. How to diagnose? Everyone knows Schirmer tear test, which is a technique to assess the quantitative tear film defect. Ideally, it should be minimum 20 over 1 minute. If it is less than 15, it is dry eye. In very bad cases, we can see even less than 5 also, 5 millimeter. So, then tear film breakup time. This one is for the assessment of qualitative tear film defect. If the tear film is not stable, it's getting evaporated or it is not adhered to the corneal surface, we can assess based on the tear film breakup time. So ideally, it takes 20 minutes. When we blink, the tear film is uniformly distributed all over the cornea, and that uniform film breaks in 20 seconds. And by that time, we blink again so that again it will be evenly distributed. So if it is less than 20 seconds before the next blink time, it starts breaking means quality of the tear film is affected. So that is the basic principle of tear film breakup time test. So in this video, if you see, we put the dye, blink once, then wait and see, you can see small breaks on the tear film has formed. So tear film is breaking.
Maybe not. Okay, okay. We'll ask them to wait. Okay, ask them to wait.
So this is tear film breakup time. So coming to the treatment of KCS, lacrimostimulants or medicines or drugs that improve or increase the tear film production from the existing functional glands, which are cyclosporin and tacrolimus. Every 8 to 12 hours we can apply. Then cholinergic agonists, these are used in neurogenic KCS, pilocarpine, but it has to be applied sublingually because direct application in the eye will be severely irritating. Then lacrimomimetics or drugs that mimic the tear. So they won't have a longer action. That is why we use lacrimostimulants. Lacrimomimetics are hyaluronides, CMC, carboxymethyl cellulose or hydroxypropyl cellulose drops, polyvinyl alcohol. These all are lacrimomimetic or artificial tear drops. Then comes the corneal ulcer, which is the most common condition which we face in our practice. So, corneal ulcer cases will be presented with photophobia, ocular discharge, which will be serous or mucoid, then severe blepharospasms. They won't be able to open the eyes because of that intense pain. Then corneal edema and vascularization, changes in the corneal curvature. So, you can see a bullous keratopathy. Here a bulla formation is there. Then lackluster cornea, again same as that of KCS. You won't see that shiny glistening corneal surface in this. Then miotic pupil. Meiosis is basically because of pain. Pupil will be constricted. This one is a bullous keratopathy where the curvature is affected. Then here there is an iris prolapse or staphyloma. So iris has come out through the perforating ulcer. Coming to diagnosis of corneal ulcerations, first one is ophthalmic examination to find out the cause of ulceration. There can be eye or adnexa changes like tear glands or eyelids, eyelashes, third eyelid, or get affected, or there is any defect in the lid closure and lid anatomy, possibly due to trauma, any lacerations on the eyelid, entropion or ectropion can cause corneal ulceration. Then reflexes, like palpebral and corneal reflexes. We have to see whether they are intact or not. Sometimes they won't have normal palpebral reflex, and that can cause the droopy palpebra and the eyelashes can cause ulceration on the corneal surface. Then comes Schirmer tear test, which is for the assessment of tear film quality and quantity, because dry eye can eventually cause corneal ulceration. Fluorescein dye test for the corneal integrity, pattern and depth of the injury. So, ophthalmic examination. So here we can see that kitten was presented with a corneal ulceration. The root cause of ulceration is this abnormally grown eyelashes. In this both pictures we can see. So, if we don't address this one and treating for the corneal ulcer, it's not going to get cured. Here there is a foreign body inside the nictitens membrane. So, there was corneal edema and blepharospasm only. Then we put a topical analgesic proparacaine drop and examined. We could find that there is a small piece of some plant material underneath the third eyelid causing the ulceration. So once we remove it and treat for the ulcer, conditions resolved. And herpetic ulcers, as we saw in the first slides, herpes virus infection in cats. Early stages, it can be punctate. Then the virus transmission between the cells forms a dendritic form. Then the dendritic forms coalesce to form a geographic pattern. So these are the different stages of herpetic ulcers. And in cats alone, corneal ulcer healing can cause focal necrosed areas known as corneal sequestruct. It will be black in color and there won't be vascular supply causing this kind of black lesions. They need to be removed surgically. We have to remove that necrosed tissue, and if the defect formed after removal is deep enough, we'll have to go for a grafting. Otherwise, we can treat it as a superficial corneal ulceration. And fluorescein dye test. 0.1% fluorescein dye is used. Either we can keep the fluorescein strip over the cornea and put one drop of distilled water, or we can mix it with 1 ml of distilled water in a syringe and use it as a drop also. So ideally, fluorescein dye does not penetrate the intact corneal epithelium and it will not stay in the Descemet's membrane. Remaining membranes or layers of cornea, it will stay. So it can be used for the diagnosis of corneal ulcers Then to differentiate indolent ulcers and for differentiating descemetocele. So what happens in corneal ulcers? There will be a uniform dye uptake. In case of indolent ulcers, there will be everted epithelial margins of the ulcer, and underneath that everted margins, seepage of fluorescein will be there. So we can see a separate margin for the ulceration. Then coming to descemetocele, Decimet's membrane will not take the dye. So it will be like a deep corneal ulcer. Margins of that ulcer will be stained and the base of the ulcer will be black in color. That's how we can differentiate descemetocele. So this one with the naked eye examination, it is little difficult unless that arrow is there to say that there is a big ulceration here. Once you put fluorescein, you will be able to see that a big ulceration is there and loose epithelial margins here, that folded loose epithelial margin. Underneath this, the fluorescein dye goes and makes a margin like this. So this needs surgical intervention also. This is another ulceration here. This is dendritic ulcer. Here, this one is a descemetocele. You can see that the margins are stained, but the base of the ulcer is not stained. Then this one is a simple corneal ulcer without any involvement of the stroma. Only the corneal epithelium is involved, and they will heal within 7 days. When it is a complicated ulcer, there will be stromal involvement, and even after 7 days, fluorescein dye test will be positive, and that time we have to interfere in the treatment. So coming to the treatment, first of all, we have to identify and remove or correct the cause of ulceration. Second one, antibiotic. Ointments are not advisable in deep corneal ulcers because they contain petrolactam vehicle, which is not good for corneal healing. There should be aggressive therapy for infected and melting ulcers, otherwise they will get worsened. Then systemic antibiotics. They are effective only in perforated or vascularized ulcers. A superficial ulcer doesn't have any vascular supply, so antibiotics are not going to reach that site if you give systemically. So they are not going to help. If it is a perforated or deep ulceration, there will be vascularization, and that systemic antibiotics will reach the site. Coming to the treatment, mydriatics or pupillary dilating agents can help in reducing the pain caused by the iris movement, repeated iris movement or reflex anterior uveitis. Most common one is atropine 1%. So that will reduce the iris spasms and the subsequent pain. But the only drawback with the use of mydriatic atropine is that it compromises tear production. Then we can think about anti-inflammatory therapy only systemically, not or topically, and prevention of self-trauma by use of a Elizabethan collar. So when a superficial ulcer doesn't heal in 7 days, you have to change the diagnosis and not the antibiotic. There will be some underlying cause for that ulceration, and that is why it is not healing. Otherwise, a superficial ulcer should heal within 7 days. So when we see a non-healing ulcer, we have to make sure that the underlying cause is identified and removed or treated. So we have to go back and re-examine again for any eyelashes abnormalities or any eyeball changes like labophthalmos, exposure keratitis, or any or herpes virus infection or a foreign body. Then sometimes that ulcer has become infected by bacteria, and this bacteria will produce proteolytic enzymes which will start melting the corneal stroma. So literally the corneal stroma will look like a gelatinous material. That means it is severely infected by bacteria. In such case, we have to go for aggressive antibiotic therapy, topical as well as oral, and most of the time we have to use a compounded antibiotic preparations also compared to the normally available ones. Then indolent ulcers. They don't heal because of the everted epithelial margins. So we have to remove that everted epithelial margins. and corneal malacia or melting ulcer, where there is bacterial infection, proteolytic enzymes are producing, and they start melting the corneal stroma. So we have to go for multimodal antibiotic therapy, a combination of tobramycin, cefazolin, tobramycin, chloramphenicol, or ofloxacin, cefazolin combinations we can use, and anticollagenase therapy like topical autologous serum, EDTA, eye drops, or oral doxycycline. Doxycycline has matrix metalloproteinase inhibitory effect, which gives anti-inflammatory action in the eye. Then infected ulcers, systemic antibiotics, topical antibiotics based on ABST results, midriatics for reducing the pain, autologous serum, EDTA drops, superficial keratectomy we can think about when it is very bad, and other surgical interventions like corneal grafting or conjunctival pedicle graft. This one is a superficial chronic corneal epithelial defect or indolent ulcer. You can see the margins and the seepage of the fluorescein dye. These needs intervention. Here also same. So for the management of such an indolent ulcer, either we can go for a diamond bud debridement, where we debride the margins of the ulcer or the non-adherent epithelium from the superficial cornea, so that healthy epithelium will form and properly adhere to the basement membrane. So if you don't have a diamond burr, we can simply use a wet, moistened uh, earbud or a sterile swab and remove the loose margins of the ulcer. But that needs sedation or at least local anesthesia with the proparacaine drops. But most of the time, that won't cooperate. We have to go for sedation. Another technique for non-healing ulcer is punctate and grid keratotomy, where we make small defects on the cornea and will improve vascular supply towards the ulcer and help it heal faster. So punctate keratotomy, multiple punctate lesions, not deep, but just to make a dent. We use a normal hypodermic needle and make multiple dents over the cornea. And grid keratotomy, we make grids over the cornea in crisscross lines all over the cornea, starting from one side of the limbus to the other side of the limbus, so that blood supply will be there and vascularization will be there and it will promote healing. And of late, we are using bandage contact lenses. It is a little difficult to maintain in pets because most of the time they remove it or they will fall off. But it is a very good modality to manage ulcers, corneal ulcers. Especially, they will help in distribution of the drug. Sometimes drug impregnated bandage contact lenses are also there. So they will give a sustained release of antibiotic, and that's how it helps in ulcer healing. Amniotic membrane transplant. There are commercially available amniotic membranes, or you can use fresh collected amniotic membrane from cesarean section. Clean it thoroughly and separate the chorion, vascular chorion, from the amnion, and use it as a graft material or as a ocular surface bandage material. This will promote healing as they contain stem cells and growth factors. And it gives the collagen matrix also for ulcer healing. And coming to redness in the anterior chamber, everyone knows hyphema, blood in the anterior chamber, or it can be an intraocular neoplasm. So reasons for hyphema are anterior uveitis, any trauma, retinal detachment, systemic hypertension causing bleeding, or bleeding disorder causing bleeding into the anterior chamber, and intraocular neoplasms that we can diagnose with the help of diagnostic imaging techniques like ultrasonography or CT scan or OCT. So this first picture is being hit in the eye. We can see complete hyphema. It's fully red and we don't know what is there inside or intraocular structures. We cannot see any of the structures. But here it is a chronic uveitis with a settled hyphema. Blood has settled in the downside. So we are able to see at least the iris and some of the intraocular structures. So coming to the treatment plan, We have to give a cage rest or mild sedation or tranquilization so that further bleeding and agitate will not happen due to agitation. We have to identify and treat the cause. What is causing, if it is uveitis or any bleeding disorder or any hemопроtozoal infection causing it, we have to identify and treat the cause of hyphema. And because of the blood and blood clot and fibrin, later on fibrin formation, there are chances for secondary glaucoma to develop. So you have to keep monitoring and intervene as and when required. Then topical and systemic corticosteroids are recommended for treatment of hyphema only after performing fluorescentitis. If there is an ulcer, topical steroids are not indicated. Then manipulating the pupil size, it is little tricky. A miotic pupil or a constricted pupil will increase the aqueous drainage because the angle between the iris and the lens will be more. So aqueous drainage will be increased so that the blood will be drained faster. But the chances of posterior synechia, attachment of that iris to the lens, is more. At the same time, if it is a mydriatic pupil or a dilated pupil, the angle between iris and lens cornea will be less, and drainage angle is smaller and can cause secondary glaucoma, but there won't be any possibility for synechia formation. So we have to act accordingly, and based on the chronicity, if it is an acute bleeding, we can try for a miotic pupil with miotic agent and manipulate the pupil size. Rebleeding can happen within first 5 days, so systemic corticosteroids are indicated. And if there is chronic bleeding or rebleeding happens, we should suspect for intraocular tumors or any clotting disorders or platelet deficiency. So for that, complete blood count and ultrasonography are indicated. So this one is an iridociliary epithelial tumor in the pupillary margin here. That is also differential for red eye in the anterior chamber. Then here also there is a vascularized mass. It's an adenoma of the ciliary body. This one is a large vascular mass with fibrin. These are fibrin clots in the anterior chamber. So in the scan, we can see it is a huge mass into the posterior chamber. Then coming to glaucoma. Glaucoma can cause redness of conjunctiva, cornea, and sometimes anterior chamber and iris also. So basically, it is the high intraocular pressure causing pain, corneal edema, disturbed vision, slow pupillary light response, and mydriasis or dilated pupil. And obviously, there will be ophthalmia in chronic cases of glaucoma. Acute phases, immediately there won't be any swelling of the eyeball. Eyeball will be of normal size. Later on, when it is uncontrolled, only ophthalmia develops. So, primary glaucoma is almost always unilateral, and there will be narrow or closed filtration angle. That angle between the iris and the lens cornea will be smaller. Secondary glaucoma is noticed with uveitis or anterior lens luxation. Lens is luxated into the anterior chamber, occupying the iridocorneal angle, so that the drainage is affected and can result in secondary glaucoma. Then superficial parts of the iridocorneal angle can be visualized with a gonio lens or a goniometer, and but we cannot see the entire iridocorneal angle. For that, we need ultrasonography or US ultrasound biomicroscopy. That also, normal ultrasonography will not help in visualizing the entire ciliary cleft. It needs high resolution like 100 megahertz frequency, high frequency ultrasound probes are required for that. So, initial medical therapy for acute primary glaucoma is aimed at rapidly reducing the IOP. So, when it is above 25, 40 and all, immediately we have to reduce the intraocular pressure. So, we can use either topical prostaglandin analogs like latanoprost or travoprost every 1 to 2 hours until the IOP is decreases. Or we can go for intravenous mannitol as an alternate, like 1 to 2 gram per kg. Then oral carbonic anhydrase inhibitors also. So first line is always intravenous mannitol, If there is no uveitis, hyphema, or lens luxation, we can go for prostaglandin analogs. And when you are using mannitol, withhold water for 4 hours after administering mannitol. And the patient monitoring is critical, especially when there is a cardiovascular or renal insufficiency for the pet. We have to keep monitoring the pet while giving a osmotic diuretic. Then oral carbonic anhydrase inhibitors decreases the aqueous humor formation in the ciliary body. Methazolamide we can use. These all are for the initial medical therapy. Then for maintaining the lower IOP, we can use combinations of topical medications like carbonic anhydrase inhibitor, like dorzolamide or brinzolamide. Along with that, beta blockers like timolol, Dorzox T is available. So alone, these beta blockers will not be efficient to control IOP, so we have to use it as a combination. And prostaglandin analogs may be used to help normalize the IOP along with the carbonic anhydrase inhibitor. So we can use Dorzox and latanoprost or travoprost in combination if there is no uveitis. And glaucoma is ultimately a surgical disease and it needs laser ablation of the ciliary body, which produces the aqueous humor. So, if we ablate or destruct the ciliary body, aqueous production will reduce, and that's how we can manage glaucoma. Or anterior chamber shunts are there for the drainage of aqueous fluid outward. Or if it is a very bad case, not responding to any management, then we have to go for enucleation or evisceration of the eyeball, which is the most humane option in most cases of blind glaucoma patients. So there are some pharmacological agents like cidofovir used into the vitreous chamber to destruct the ciliary body and reduce the intraocular pressure. Either cidofovir we can use or gentamicin injection also can be used when the pet doesn't have vision and need a comfortable life without removing the eyeball. So most of the pet parents like to keep that eyeball for that aesthetic purpose, or they feel bad for removing the eyeball. In such cases, to reduce the pain and make the pet comfortable, we can try these techniques also. Then coming to redness of iris or iridial hyperemia, it's very common in anterior uveitis, sometimes in intraocular neoplasms, and in bleeding disorders. So here there is iris neovascularization or seen here and here, and there is episcleral ingestion and meiosis secondary to anterior uveitis. It's not a separate disease, that's why I didn't mention much. Coming to anterior uveitis, it is the inflammation of uvea, that means the vascular part of the eye, which includes iris, ciliary body, and the choroid. So anterior uveitis means inflammation of iris and ciliary body. There will be redness of eye due to episcleral injection on the conjunctiva, 360-degree deep corneal vascularization, red eye on the cornea, hyphema in the anterior chamber, and rubeosis iridis. That means in the iris. So all these four parts will be red in anterior uveitis, or the degree of redness varies. Then aqueous flare is a major clinical sign associated with anterior uveitis. Aqueous flare means there will be cloudiness of the aqueous humor. So you can see particles moving inside the aqueous humor if you put a slit lamp light. And sometimes there can be fibrin or pus or keratitic precipitates in the anterior chamber, keratic precipitate on the corneal surface. Then because of pain, there will be blepharospasms, excessive tearing, and constricted pupil. And most of the time, anterior uveitis, early stages will have a low intraocular pressure. If it is secondary to glaucoma or uveitis causing glaucoma, pressure will be high. Otherwise, it will have a low IOP, like sometimes, most of the time, less than 5 or 10, it will be. So it can be either systemic uveitis or non-systemic. Non-systemic uveitis means secondary to cataract, lens-induced uveitis. Lens protein is leaking out through the lens capsule and causing uveitis. Then corneal ulcerations causing uveitis, intraocular neoplasms, and other external evidence of trauma can cause non-systemic uveitis. Systemic uveitis can be due to autoimmune, infectious, neoplastic, and other reasons like endotoxemia or idiopathic or metabolic. Coming to the treatment of uveitis, first we have to address the primary cause and decrease pain and inflammation. So, to reduce the pain and inflammation, we can use atropine 1% eye drops, which will relieve the miosis and pain, and the iris spasms it will reduce. But it should not be used in patients with normal or elevated intraocular pressure because it can increase the IOP. Then prednisolone acetate 1% of ophthalmic suspension or topical NSAIDs can be used to reduce intraocular inflammation, but make sure that there is no corneal ulceration. Then systemic NSAIDs like meloxicam, firocoxib, or carprofen can control inflammation, and they can be used when there is a corneal ulceration also. But we should consider concurrent diseases like hepatic and renal function before using NSAIDs systemically. Then systemic glucocorticoids, before using them, rule out infectious causes and neoplasms requiring chemotherapy like lymphoma. Then coming to the redness in fundus or red reflection, it can be a normal variant or atypical or hypopigmented fundus. Especially we see that in husky breeds, red reflection, that is a normal variant. Then posterior segment hemorrhage or retinal hemorrhage. Retinal hemorrhage can be due to retinal detachment, chorioretinitis, systemic hypertension, bleeding disorders, or intraocular neoplasms. So in this one, we can see vitreal hemorrhage in the right eye, obscuring the fundic reflection in a cat. It's very common in systemic hypertension secondary to renal failure in cats. Then this one, husky, it's a normal variant. There's nothing abnormal. It's only hypopigmented retina, so that the fundic reflection is more red. Here there is a retinal detachment with small hemorrhagic spots. And the retinal vessels we can see without the use of L lens. These are also retinal detachment. It's not that clear, but I hope it is visible that we can see a white veil kind of structure, which is a detached retina. And the pupil is completely dilated. Here also, we can see all the vasculature, optic disc and all without the use of an ophthalmoscope or a magnifying lens. So these are the possible causes of red eye. Then comes the blue eye. Blue is not exactly blue, it can be white also. But in general, I just classified them as blue eye. Most common one is blue discoloration on the cornea. It can be either corneal edema or crystalline dystrophy, like calcium or lipid dystrophy. So corneal edema can be focal, localized to one area due to the loss of epithelial cell barrier, or like corneal ulcerations, or it can be diffuse from corneal endothelial cell pathology. From the inside of the cornea, if the endothelial cells are damaged, it will affect the water inflow and outflow to the corneal stroma and can cause a diffuse corneal edema. So whenever there is a corneal edema case presented to you, first etiology that should be rolled out is glaucoma because it is the most immediate threat to vision and comfort. It will be very painful and can affect vision. So first thing we have to roll out is glaucoma. And other than that, corneal ulcers, anterior uveitis, anterior lens luxation, or endotheliitis can cause this corneal edema. So endothelial dystrophy is a progressive bilateral disease and resulting in the dystrophy of endothelial cells, causing abnormal water inflow into the corneal stroma, causing diffuse corneal edema. And the treatment is aimed at preventing secondary corneal ulcers. Because of the water inflow, small bullae will form in the cornea. Then these bullae will rupture and will form corneal ulcers. So we have to prevent that. So coming to the diagnostics for a corneal edema patient, Schirmer tear test and fluorescein dye test, then intraocular pressure, most important one. So when there is a corneal edema case presented, first check the intraocular pressure. If it is increased, then it can be glaucoma, anterior lens luxation, or intraocular surgery, post-surgery edema. If the IOP is normal, then we have to see whether there is an ulceration or not. So in the first picture, you can see a lacy appearance of the corneal edema secondary to anterior lens luxation. You can see the lens is outside, anterior in the anterior chamber. It came in front of the iris. Here we can see the iris margin and the lens margin is visible down to the iris margin. That means lens is dislocated anteriorly. And here there is a diffuse corneal edema secondary to corneal endothelial dystrophy. Corneal endothelial, but still it is not fully edematous, almost diffuse, but still here we can see some level of. But this last image, it's fully edematous. It is an advanced endothelial dystrophy. Corneal endothelium has completely damaged, causing this much edema. Here, corneal endothelium edema secondary to anterior uveitis. So here there is the 360 deep vascularization due to anterior uveitis. Coming to treatment of corneal edema, can be medical or surgical management of glaucoma, lens luxation, and uveitis. Endothelial dystrophy or decreased endothelial cell density causing edema and, should be attended for preventing corneal ulcerations, because this is a small bullae which will develop into ulcers. So we can use 5% sodium chloride or hypersol solution topically that will absorb the water from this trauma and will reduce the edema. Sometimes it is not that enough. So we can use topical pro-associated kinase inhibitors, ripazobil eye drops. They are found to be effective in almost 67% of corneal edema due to endothelial dystrophy in a study. They actually help in endothelial regeneration or endothelial healing. So water reabsorption will be promoted, and that's how they reduce the corneal edema. Then thermokeratoplasty is a surgical technique. So using a thermocautery, it causes multifocal contractions on the anterior stromal fibers like this, so that the water will not retain there, it will come out. But this can cause severe vascularization and scarring and all in future. Same way like this, we can use punctate or grid keratotomy also for managing corneal edema, which is not responding much to the other medications. Then adenovirus infection or vaccination causing corneal edema. Because of a natural infection or a modified live vaccine for adenovirus can cause type 3 hypersensitivity reaction, thus forming immune complexes in the aqueous fluid. These immune complexes will be phagocytosed by the neutrophils and macrophages, and they can be cytotoxic to the endothelial cell death happens, and thereby edema develops. In such cases, treatment with topical steroids are effective, and most of the time it regenerates and recovers naturally. Then endotheliitis is a primary inflammation of the endothelial cells. There will be severe edema, and usually it will be worse in the ventral aspect rather than the dorsal aspect. And because of the inflammatory nature of it, there will be conjunctival hyperemia, blepharospasms, and keratic precipitates, like small precipitates on the cornea. Then we can follow anti-inflammatory therapy. And this ripazobil or Rho-associated kinase inhibitors can be used. So then another reason for corneal edema is intraocular surgeries. The medicines or drugs or agents used for intraocular surgeries, like for cataract surgery, we use irrigation solution, then mydriatic agent. All these can cause corneal endothelial cell damage. Almost 22% of the endothelial cells are washed out in phaco surgeries. So imagine how much they can cause corneal edema post surgery. So this is a case of post-operative images of a cataract surgery. On the third day, it was almost fully cornea edematous cornea with the keratoconus also. The curvature of the cornea was affected. Same day. On sixth day after using, we were using topical sodium chloride uh, eye drops. So this is on third day. Marked reduction is there, and this is by the sixth day. Edema is only restricted to the surgical site alone. Then crystalline dystrophies. They are likely hereditary in etiology. They can be cholesterol, phospholipids, or free fatty acid accumulations within the cornea. They are not associated with any other corneal or ocular inflammation, and most of the time they are harmless and there won't be any pain or disturbance to the pet. So sometimes there can be abnormal serum biochemistry values like high elevated cholesterol and all. In such cases, dietary modification can be advised, but sometimes without any serum chemistry abnormalities itself, they get this lipid dystrophies. So corticosteroids are not indicated in such cases because they can further aggravate it. If there is ulceration or mineralization, calcium deposition secondary to the dystrophy, or if the pet is having any discomfort because of this, we can think about superficial keratectomy. Then blue discoloration in the anterior chamber can be due to a fibrin clot or a excited lens or a lipemic aqueous, means lipid seepage into the aqueous fluid. So this cat usually that happens bilaterally, but unfortunately this or fortunately this cat had unilateral lipemic aqueous. Here there is a luxator lens in the anterior chamber. Here there is a lot of fibrin clots in the anterior chamber. So all this gives a blue shade. Then coming to lens opacity that gives a blue eye appearance. Everyone knows nuclear sclerosis and cataract. These are the two causes for changes in the color of lens. So nuclear sclerosis means it's an age-related change. Actually, the lens cells develop continuously and they get compacted in the center of the lens as the pet ages. So they look more opaque because of the densely packed cells in the center. But that is not going to affect vision, and it gives a lens within a lens appearance. And if you use an ophthalmoscope or a bright light, you can see the fundic reflection. But in cataract, you won't be able to see the fundic reflection. That is the difference. So it will give a typical appearance like this in this picture, nuclear sclerosis. Then comes cataract. The word cataract came from the Latin word meaning waterfall or a furious rush of water. So cataract develops due to alteration in the soluble-insoluble protein ratio of the lens material. So it happens because of an increased proteolytic enzyme activity or sometimes alterations in the lens nutrition or osmotic balance as in case of diabetes, energy metabolism and protein metabolism. And sometimes it can be due to lens fiber rupture and cell death due to some trauma or radiation. So these are the different types of cataract. Anterior capsular cataract. Then here there is a cortical cataract. And here posterior nuclear cataract. Fetal nucleus will be present in congenital cataract. Typically in the center alone you will see that opacity. Then this is a posterior subcapsular cataract. And this is the suture on the Y suture of the lens. There is opacity. These all are different variants of cataract. Then, based on the stage of cataract development, in CPN cataract is the early small opacity in the lens. Most of the time, pet parents will not even notice that. Even we won't notice that unless we go for a dedicated ophthalmic examination because the pet is able to see. Then comes the immature cataract, which is easily observed and it will be more diffuse and the pet will still be visual because it doesn't block the light to the fundus. Then the mature cataract comes. That means complete opacity. There won't be any light entering into the fundus, so the pet will be obviously blind. And there will be normal PLR and dazzle reflexes with bright light, but Nana's response will be absent. Dazzle means when you show light, blink reflex. So then comes the intumescent cataract, where the lens material gets swelled up, forming water clouds. After swelling, it started breaking and so forming water clouds in between. This is the intumescent cataract, very common in diabetic cataracts. Then another one is next stage is the hypermature cataract, where the resorption of water starts. So it swelled up, then the water started getting resorbed. So there will be shrinkage of the cortex, and there will be calcified deposits on the cortex, and this granular texture due to the shrinkage and reabsorption of water. Then Morganian cataract. That means it is almost resolving stage. That cataractous material started getting liquefied and it starts settling in the ventral aspect of the capsule. So dorsal side it will be more clear, and only ventral side there will be cataract. And sometimes PET may gain vision at this stage of cataract. Then anterior and posterior lens luxation. I kept both the pictures together so that we can compare or appreciate the difference. In anterior lens luxation, lens comes anterior to the iris. So here the iris margin will not be properly visible, and lens margin you will be able to see in front of the iris. In posterior lens luxation, we can see the lens margin behind the iris, and half of the lens will be behind the iris and you won't be able to see. And we can see a crescent shaped part of fundus not through the lens, that forms the aphakic crescent. So anterior lens luxation is an emergency and we have to immediately remove the lens. Otherwise, it can block the iridocorneal angle or the drainage angle for aqueous humor and can result in secondary glaucoma. Posterior lens luxation is very difficult to operate most of the time, and even if we leave it as such, it is not going to cause like severe complications like secondary glaucoma. For the treatment of cataract, in vitro treatment with lanosterol has found some effect, but in clinical cases, I didn't find any good result with the use of lanosterol drops. Other medicines that claim to give result for cataract, which is available in market, some nutraceuticals and all, they are not at all effective. But lanosterol, at least one research publication is there, but still I didn't find them clinically effective in managing cataract. Then comes the surgical management, which is the gold standard for cataract treatment. We can go for either intracapsular cataract extraction, removing the cataract along with the capsule, or leaving the capsule there, removing the lens, cataractus lens alone. Phacoemulsification is a modification of this extracapsular cataract extraction. We make an opening on the capsule, put the phaco probe inside, dissolve the lens material and aspirate it, and the lens capsule will remain there. We can either put an artificial lens or leave it as such. Either way, PET will have vision and if all other structures are healthy. So postoperative emmetropia or normal vision can be achieved by implantation of artificial lenses. We universally use 41 diopter canine IOLs. Even without an artificial lens, pets can have vision because 70% of the refraction in canine and feline eye is contributed by the cornea, not the lens. In human, it's not like that. Lens is necessary for maintaining vision. But in pet, dogs and cats, cornea will take care of the refraction. So 70% vision can be promised if other structures are normal post surgery, even without an intraocular lens. So complications of cataract or lens-induced uveitis can be phacoclastic uveitis because for after a rupture of the cataractus lens, there will be exposure of lens protein to the aqueous humor causing a uveitis, or phacolytic uveitis means slow release of the protein, lens protein, slowly leaking through the capsule causing uveitis. So these reactions are less severe in younger animals and it is more common in diabetic cataracts. So Severe forms can occur in hypermature cataracts and with the older dogs. There will be severe pain, photophobia, corneal edema, ciliary blood vessel injection, then aqueous flare, constricted pupil, uh, keratitic precipitate. These are the keratitic precipitates. And low pressure. In such uveitis cases, we have to aggressively treat with the anti-inflammatory therapy. So these are the red eye and the blue eye. Next one is the blind eye. So basically, there are five possibilities for a blind eye. One is blind with light does not reaching the retina. Second one, blind with the ophthalmoscopic examination is abnormal, but pupillary light response is present. Third one, ophthalmic or ophthalmoscopic examinations are abnormal and there is no PLR. Next one, ophthalmic examination is unremarkable. There is nothing much to say, but there is no PLR. Then unremarkable ophthalmoscopic examination and a positive PLR, but the pet is blind. These are the five possibilities. But anyway, for the examination of retina, we need a direct or indirect ophthalmoscopy. So, first possibility is that the light does not reach the retina. Basically, with an ophthalmoscope, if you examine, if you cannot see the retina, that means the retina also cannot see you. So it can be due to opacity anywhere along the optical pathway, like corneal pigmentation or corneal edema, then infiltration in corneal edema, then aqueous humor transparency like hyphema or hypopyon, or lens opacity means cataract. Any of these can cause an obstruction in the optical pathway of light and causing blindness. So if it is corneal pigmentation, we have to examine for any corneal diseases. If it is edema, consider corneal ulcers, uveitis and glaucoma. Then hyphema can be due to systemic hypertension, coagulopathies, trauma, infections, or diseases that cause anemia or thrombocytopenia also. Hypopyon can be due to systemic inflammatory or infectious diseases and advanced cataracts. Then, in a blind dog with light not entering retina can happen in case of severe blepharospasms. Eyes are kept closed or extremely miotic pupil due to severe pain. In this case also light will not reach the retina. So we have to check for any potential cause of pain like ulceration, foreign bodies, eyelid or eyelash abnormalities. Then another cause is vitreous haze. Any inflammation or bleeding in the vitreous that can cause obscured vision, obscured light penetration to the fundus. So we have to evaluate for intraocular diseases like tumors in such cases. So these are the reasons for light does not reaching the retina and the dog is being blind. And second possibility is on ophthalmoscopic examination, there is something abnormal, but pupillary light reflex is present. It can be due to progressive retinal atrophy. It's an early, progressive retinal atrophy. In such cases, there won't be much changes on ophthalmic examination in the early stages, and it will be limited to the periphery only. But in later stages, we can see classical signs of tapetal hyperreflective, like bright reflection from the fundus. There won't be any blood vessels or very thin blood vessels on the fundus. PLR can be present in the early stages, but later on they diminish or completely get absent and the pupil will be completely dilated. There is no effective treatment for progressive retinal atrophy. It is a degenerative change. Then retinal inflammation or chorioretinitis. In that, there will be focal or multifocal inflammation on the retina, and there can be partial vision due to the unaffected part of the retina. And PLR can be positive because some parts of the retina are still functional. So in this picture, it is a terminal progressive retinal atrophy. There is no vasculature, there is no blood vessel at all on the cornea, and tapetum is hyperreflective. This area is hyperreflective. Optic disc, there is no blood vessels, and it looks like a grayish disc. So that is progressive retinal atrophy in the later stage. Then comes the third possibility. Ophthalmoscopic examinations are abnormal. There is visible abnormality and there is no PLR. That can be due to acute blindness and a fixed dilated pupil in glaucoma. That would be ophthalmos, corneal edema, episcleral congestion, and optic disc cupping, vascular attenuation, and no PLR. Then proximal optic neuritis. There will be inflammation of the optic disc, edema, congestion, hemorrhages on the optic disc. Sometimes disc will be elevated and around the disc there can be retinal detachment also. This leads to optic disc atrophy and we can see around brown gray disc only, no vasculature. And retinal detachment. Uh, we saw that in the video, there will be a vascular white gray veil behind the lens and there will be varying degrees of subretinal hemorrhage. There can be systemic hypertension, infections, or vascular diseases causing detached retina. So in this picture, this one is an optic disc atrophy. There is no blood vessel, you can see, and it is like a gray color disc. And this one is a normal optic disc. You can see all the blood vessels, and it is more pinkish in color. Then the next possibility is ophthalmic examination is unremarkable. There is nothing much to see in ophthalmoscopic examination, but there is no PLR. That is very common in sudden acquired retinal degeneration, SARD, or optic neuritis. So to differentiate these two, we have to you go for an electroretinography. In SARD, electroretinography will be absent and there is no treatment. But in optic neuritis, especially early stages, there can be a normal electroretinography and it can be caused by infectious diseases or granulomatous meningoencephalitis and there is treatment for it. If we interfere in the early stage, we can save vision. So in this situation, electroretinography is very important. Then comes ophthalmic examination is unremarkable and PLR is present. Still the dog is not visual. There is no lesion in the fundus, no lesion in the eye. PLR is also normal, but the animal is not able to see. This can be neurological. In these conditions, there will be a positive PLR because the lesion is in the distal visual pathway or the cortex of the brain. And it can be congenital blindness, any inflammatory conditions in the cortex, infectious conditions in the cortex, or metabolic diseases of the CNS, central nervous system. Then some of the nutraceuticals, so these are the major lesions, red, blue, and blind eyes. I just would like to say a few words about nutraceuticals and supplements used in veterinary ophthalmology for the management of these above mentioned conditions. Omega 3 and omega 6 fatty acids are important in maintaining the lipid layer of the tear film. So, when there is a qualitative tear film defect, we can supplement with omega 3, omega 6 fatty acids. It will stabilize the tear film. Then, other than that, these are required for the optic nerve layer or the retina for retinal health. Myelination will be affected with the deficiency of omega 3 and omega 6 fatty acids. So, we can supplement in optic neuritis and other degenerative conditions also. Then, curcumin or the extract from turmeric has a synergistic action with antiviral medications for herpetic ulcerations and herpes virus infections. It has anti-inflammatory and antioxidant properties, which is useful for inflammatory conditions like uveitis or vitritis. And problem with curcumin is that it has a very poor bioavailability, so we have to rely on nanocurcumin products. Then alpha lipoic acid is an aldose reductase inhibitor and a potent antioxidant. So it can be used in diabetic cataract patients, which delays and potentially prevents cataract development. Then bilberry extract. Bilberry extract is available as glow eye tablets. So they contain anthocyanins, which are powerful antioxidants. Then grapeseed extracts, lutein, omega-3 fatty acids again, vitamin A, vitamin C, alpha lipoic acid, coenzyme Q10, and lycopenes are also very good antioxidants, which can be used for ocular regeneration and for the degenerative conditions. So these are the some of the nutraceuticals used in ophthalmology. Coming to ocular ultrasonography, which is a very helpful diagnostic tool in small animal ophthalmology, especially when there is opacification of ocular media, as in corneal opacity, hyphema, hypobar, or meotic pupil, or in cataract. We cannot see the fundus or the structures behind that opacity, then we can rely on ocular ultrasonography. Ophthalmos, or the swelling of the eyeball or stretching of the eyeball due to increased intraocular content. Exophthalmos, pushing the eyeball due to something behind the eyeball. Then strabismus or squint, lateral deviation of the eyeball, or to distinguish between anterior chamber entities. Sometimes it can be a cyst or it can be a tumor. To differentiate what it is, we can rely on uh, ultrasonography. So, first image, there is an opacity in the cornea. We cannot see anything behind that. Second one, anterior chamber opacity. There is severe hyphema. We don't know what is behind that. We can't see iris or lens or fundus. Third one, lens opacity, cataract. Iris we can see, cornea we can see, anterior chamber we can see, but vitreous and fundus is not visible. Then here there is a structure in the anterior chamber. We are not sure whether it is a cyst or a solid mass. So in such case, we can rely on ultrasonography to differentiate what it is. And here there is a small growth visible, but we are not sure whether it is a small growth limited to that area or it is extended inside. So to identify that, we can depend on ultrasonography. Then chronic glaucoma. So chronic glaucoma, there will be opacity, and we can find out is there any in underlying pathology by ultrasonography. So this image, there is bulging of the eye and third eyelid prolapse, means there is an this is an exophthalmos, means eyeball is pushed forward. But in this image, third eyelid is not so prominent, but there is this image, there is third eyelid is not prominent, but there is stretching of the cornea and the eyeball is bulged. This is ophthalmos due to increased intraocular content or inside the globe. This is behind the globe, something is pushing. And here there is medial strabismus. Eyeball is medially deviated. So something is pushing the eyeball from lateral side towards the medial side. So in such cases, we can identify the cause of these through ultrasonography. Coming to the equipment, being a superficial organ, we can use a high frequency transducer with the low penetration, at least 7.5 megahertz, even up to 20, 7.5 to 20 will be very useful. Even up to 100 megahertz transducers are used for detailed evaluation of cornea and the layers of cornea and all. But what we have is usually 7.5 megahertz that we can use, and a linear transducer is ideal, or a sector or vector transducer can be used. And being it is a very superficial structure, we need a standoff pad to make the contact proper. So standoff pads are available in market, or we can use a glove filled with gel or water and keep it over the cornea and use it as a standoff pad. It will give a gap between the uh, probe and the structure so that we can visualize properly. So for the placement of transducer, we have to use a topical anesthetic, preferably proparacaine 0.5 percentage. One drop in 5 minutes interval for 3-4 times will give enough analgesia. Then we can place the probe either over the cornea or close the eye and keep it over the eyelid or palpebra. So coming to the patient handling, the patient should be positioned in such a way that the eyeball is placed centrally. It should not go ventromedially or laterally. Either you can keep the pet on sternal recumbency preferably, or if the pet is very aggressive, we can give sedation and position the eyeball with the stay sutures or speculum, like mentioned in this picture, and position it centrally. So there are basically three views for ultrasonography: longitudinal and temporal views. So this one is a transverse view. The probe is positioned horizontally over the cornea. This transcorneal approach. Over the cornea, directly I place the probe. I'll show once again. This is how I keep the probe. And second one is the longitudinal. First one was transverse. This is the longitudinal. Exactly perpendicular to the transverse view, we keep the probe. It's not so comfortable. And the third one is temporal view, which is very helpful in identifying retrobulbar behind the eyeball lesions. So we keep it in the temporal aspect of the eyeball so that we can see the retrobulbar structure. So we can see the retrobulbar structure. This is the eyeball, and here is the retrobulbar area. Once again, this is the temporal view. These are the three views. So how we see a normal eye on ultrasonography. So see the normal eye, we can compare. This is the standoff pad. First layer we see is the anterior corneal epithelium. Then in between the corneal stroma. And second line is the corneal endothelium. This much clarity might not be there with the 7.5 megahertz transducer. We need 20 megahertz at least to get this much clear view. And then comes the anterior chamber. So corneal epithelium, stroma, endothelium, and the anterior chamber beneath that. Then second anterior chamber, anterior lens capsule, posterior lens capsule, and the ciliary body holding the lens. This is the entire lens. A normal lens will be visible as one line above and below only. Inside it will be fully black. Then behind is the vitreous, which is again fully anechoic, and retina. A thick area will be there because of the myelination. It will appear hyperechoic. That is optic disc. Then optic nerve behind that. This one. And either side retrobulbar fat. So this is the structure we see on a transverse view of normal eye. Ocular biometry, we take some measurements to assess the lens size before cataract surgery, sometimes for assessment of glaucoma or intraocular structures. So basic biometric measurements are anterior chamber depth, vitreous chamber depth, lens axial length and equatorial length, and the total globe length. These are the measurements we take, and these are the normal values. I'll share that later. Coming to abnormal eye. So anything in the abnormalities in the cornea like infiltrates or degenerations or edema, that is little difficult with a low frequency probe. Higher frequency probe is required. Anterior chamber space occupying lesions, iris lesions, synechia or attachment of the iris to the cornea or the lens. Then lens cataract or dislocation of the lens, or the posterior capsule of the lens if it is ruptured or damaged, that we can see. Then vitreous face occupying lesions, vitreal degeneration, then some congenital conditions like persistent hypoplastic primary vitreous, then retinal inflammation and detachment, subretinal fluid accumulation, optic nerve neoplasms and edema, retrobulbar abscesses and tumors we can see with the ultrasonography. So anterior chamber space occupying lesion. There is a lesion in the anterior chamber. We don't know whether it is a tumor or a cyst. So if you go for ultrasonography, a tumor will look like a solid, like uniform echogenic structure. A cyst will look like an anechoic center and a hyperechoic margins. So that's how we can differentiate a tumor and a cyst. Iris cysts are very common in cats, which is not dangerous also. So again, there is a thickening of the iris. This is the lens, cornea, lens anterior capsule, posterior capsule, vitreous. Iris is markedly thickened, which is indicative of an iris melanoma. And here there is a thickened iris with multiple anechoic pockets, cavitary lesions. Iridial cystitis is common in cats. Then posterior synechia or attachment of the iris to the lens. So we can see from this picture, iris is folded backward and attached to the lens, and it is 360-degree, it is like that. So what happens is that aqueous humor produced behind the iris is not able to come out through the pupil and get drained. So that causes secondary glaucoma. So normal eye, there will be aqueous production from here between the lens and iris. It will come out through the pupil and will get drained through the iridocorneal angle. So when there is a obstruction or a narrow angle glaucoma, this drainage is affected and the fluid gets accumulated between the iris and lens, causing iris glaucoma. Just 1 second.
You are busy? Yeah, there's one case waiting that cystoscopy.
Okay. It will take some more time. It will take some more time.
How much time more? I asked them to come or that's it, because they are unable to come tomorrow morning. That's the reason.
If they can wait. Wait.
More than 2.5 hours.
They can come tomorrow.
No, you can't. That's the problem.
Sorry. So in this picture, we can see extensive irregular thickening of the iris and the ciliary body, which is suggestive of an iridociliary carcinoma, and lens is posteriorly luxated. Lens is supposed to be here, but it luxated back. Coming to cataracts. So normally, as I said before, lens will be visible like one line above and one line below, and inside it will be fully anechoic. But when there is cataract, we can see echogenicity in between the anterior and posterior capsule. This is a full cataract here also. And here one more thing we can see is that there is a dent on the posterior capsule of the lens. Then again, these all are different types of cataract. Here there is retinal detachment also. So this one is a diabetic cataract. Previously I have shared the normal values. Usually lens thickness will come somewhere around 7 to 7.5 millimeter. But here you can see it is 8.7 millimeter thick big lens, intumescent cataract, which is very common in diabetes. And here we can see that the posterior capsule of the lens is ruptured. Again, another posterior lens luxation of lens with a huge big lens. Here there is a vitreous tumor. So it was arising from the medial aspect of ciliary body and invades inward. So when we see from outside, it will be a small tumor on the ciliary body. But when you do the scan only, we realize the gravity of the growth. Then this is a congenital condition where normally in a fetus there will be a vascular supply from retina to the lens, and as the fetus is postnatal stage, that vascular supply will get regressed and it will disappear, but sometimes it persists even after neonatal stage. So that vascular cord will be attaching to the posterior capsule of lens, causing an opacity on the lens, the center. And on ultrasound, you can see either a vascular or a fibrous cord connecting the lens and the retina. It's a congenital condition. Then vitreous, changes in the vitreous. liquefaction of the vitreous. So these two are same images. Only change made is that we have increased the gain a little bit. By increasing the gain, because acoustic gain from vitreous is very less. So if you increase the gain, you can see the liquefactive changes in the vitreous. Then retinal detachment. So classical appearance of a retinal detachment is the flying seagull appearance, or like small kids will draw the birds, not like that, flying seagull appearance. Retinal detachment will be there on the either margins and at the optic disc area. And in between, here fluid accumulation will be there, and the retina will be lifted forward. So it gives this body appearance here like this, and beneath that it's a fluid accumulation. Here also we can see the similar pattern of retinal detachment. There is some hyperechogenic fluid in the subretinal space. Can be a cellular infiltrate, hemorrhage, or a tumor. So I would like to share three cases actually, because I found them informative and interesting. This one is a puppy, 7-month-old puppy. So it was started all. It's all started only, and veterinarian suspected for proptosis, which is very common in Shih Tzu breed. So immediately he did a temporary tarsorrhaphy, but within days itself, eye started swelling, and it became like this. And when they presented to us, it was in this stage like this. So it is like crossed eyeball, and we removed the stitches. It was totally damaged. So on detailed examination or open mouth examination, we could find that there is a growth in the oral cavity on that side alone. And we did a scan. This is the temporal view of that eyeball. Here is the eyeball. It is totally damaged, and behind the eyeball we can see a huge growth, which is almost 13 into 9 millimeter square size. So that was causing the proptosis or exophthalmos. Eyeball was pushed forward. You can see the third eyelid is also elevated. Most of the cases, exophthalmos will be associated with the prominent third eyelid. So whenever there is bulged out eye and a prominent third eyelid, suspect for a retrobulbar tumor, and can do an ultrasonography and differentiate it also. So the pet parent didn't wanted to go for any interventions. So yeah. So this much big tumor was there inside. But it was rapidly developing also. We couldn't do much to help the puppy. Then this one is Harry Potter, beagle. He came with a little discoloration on the sclera, but it gradually started spreading, and there even little focal edema in the cornea, tumor mass. We tried to do an ultrasonography, but we couldn't diagnose much ultrasonography. Then we referred for CT scan, and we could find a 5.3 millimeter size growth in the uvea. It was a melanoma, so we had to do enucleation for that. So it was just a small patch of pigmentation which started spreading and affecting the cornea also. So this is a limitation of regular ultrasonography. Maybe we need a high frequency ultrasound, or we have to rely on CT scan or OCT, optical coherent tomography. This one is Loki, an indie dog with the bulging of the third eyelid. Intraocular pressure was very high, and there were obvious signs of glaucoma also, ophthalmos also. At the same time, eyelid was also elevated. So we did a scan. In that scan also, see, if you see, this is the right eye, down one is the left eye. Comparing the sizes of the right eye and left eye, right eye is 19 millimeter and left eye is 20.69 millimeter. Right eye anterior chamber is 1.94 millimeter and left eye anterior chamber is 3.56 millimeter. So there is an obvious difference in the size. So and we couldn't find any retrobulbar growth also in scan. But still, the third eyelid was elevated and we suspected for a growth behind. Even though we started treatment for glaucoma, we referred for CT scan. Unfortunately, I don't have the CT images, but it came out to be a tumor in the nasal cavity or the yes, nasal cavity causing this pushing of the eyeball. Slowly, that pet started developing nasal bleeding, and it got aggravated and was euthanized later. So, optical coherence tomography is an advanced imaging technique which is high resolution imaging modality. It is similar to ultrasonography, where ultrasonography uses sound, OCT uses light, and it gives an image which is almost equivalent to a histology image. So, here you can see the layers of retina similar to a histology image under OCT. So this is even advanced technique which is very useful for the diagnosis of many corneal and retinal affections, but little costly. This one is the optic disc cupping. That optic disc is depressed downward. Usually in glaucoma we can see cupping of optic disc. Here you can see this is a corneal edema. You can see multiple small bullae filled with the fluid. So that much detailed imaging we get through OCT. So these techniques, if we can adopt in our practice, it will be a great achievement, but might take time. Hopefully, all these advanced techniques will come soon in our practice also.
Thank you, ma'am. Any questions?
Excuse me, how can we measure the intraocular pressure?
We have different types of tonometers. We use a Scheidt tonometer. For that, like we have to restrain the pet, and it is little like painful also, difficult also for the pet. Then, other than that, we have tonopen, which is applanation tonometry, that has lesser contact time and contact area. Then advanced one is rebound tonometry, tonovet is available. So it's even comfortable, more comfortable for the pet. So either one we can use. If you don't have anything, just close the eyelid and use thumb pressure, like how much pressure is required. That if you practice in trying in every patient or every case coming to hospital for vaccination or normal checkup, you will have an idea of normal tonicity of the eyeball and you can appreciate changes in the eye pressure. That is just a basic idea to see whether the eyeball is tensed or not.
Is it the same that we use in human, the tonometer?
Ma'am, in cases
We
of
have
diabetic cataract,
yes.
yeah, ma'am, in cases of diabetic cataract, which is just developing, you mentioned some
Okay.
reductus
Uh,
and is
it's
it
not
available now?
clear.
And how effective is it?
No,
Hello?
it was not clear. Could you please repeat?
Yeah. Can you hear me now?
Hello? Yes.
Hello? Yeah. So in
Hello?
cases of diabetic cataract,
Ah,
yeah, ma'am, can you hear me?
hello. Yes, I
See,
can
Yeah.
hear you.
Can you
Please.
hear me?
yes, you can tell.
Yes.
Yes.
So So I was saying in cases of diabetic cataract, which is just developing.
Ah,
Hello,
Hello, you can tell.
hello,
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 hello.
hello. I think there is some network issue.
Yeah, yeah. Am I still audible?
Yes.
Am I audible? Yeah, yeah. I can hear you, ma'am.
Or maybe you can comment in the type
Am I
in the
audible,
comment
ma'am?
box.
Am I audible? Hello, hello.
Hello.
Yeah, regarding the shimmer test, how long should we keep the strip inside to take the reading?
1 minute, sir. 1 minute, 1 minute. So in 1 minute, it should be minimum 15. If it is above 20, it's normal. Less than 15 goes means it is early KCS, and if it is less than 5, it is worst case of keratoconjunctivitis. 1 minute we have to keep it. And make sure that when you take the shimmer tear strip, not touching the edge which goes inside the eye, because sometimes our hand will have some oil and all that can affect the
Oh,
reading.
yeah, yeah. So that the part we should insert the eye, we should not touch that.
Yes, fold it inside that paper cover itself and keep it inside.
Okay, okay. Thank you.
Questions?
So what kind of eye lesions
Hello.
we can hello?
Hello.
Hello. Hello, madam.
So
Uh,
what kind of eye
Yes.
lesions we can see in case of FIP in cats, or how can we differentiate it with other symptoms or other type of eye lesions?
Hello. Hello.
Hello. Dr.
Am I
Kavita,
audible? So in FIP, there can be anterior uveitis, symptoms of anterior uveitis. There can sometimes it can cause third eyelid elevation, unilateral or bilateral also. Anterior uveitis signs means blepharospasms, pain, then meiosis, and aqueous flare. And some retinal lesions are also noticed in FIP, like detachment and hemorrhage. It's little difficult to differentiate FIP based on ocular lesions because it's more of like generalized lesions, not something specific like herpetic ulcers. Herpes ulcers will have that dendritic pattern and all. This will be more of a generalized lesions.
Hello.
Hello.
Hello, madam. Madam, you have
Yes.
mentioned different types of cataract, and
Yes.
which in which type we can do that ECC extra capsular cataract extraction. In which type we are doing, or when